Okay guys, what I'm going to do today is I'll introduce the next series of videos that we're going to be looking at over the next 3 to 4 videos. It's going to be around critical thinking of the shoulder and structures of the shoulder for exercise selections, programming and so forth. So today what I'm mainly going to be talking about is the shoulder itself, so looking at structures, looking at functions, looking at the main kind of ideas and the main kind of considerations that you want to have around the shoulder before selecting your exercises. In this series we're also going to talk about dysfunctions, injuries, common injuries from acute sporting injuries just to normal biomechanical dysfunctions and muscular imbalance and so forth. And in the final video within the series we're going to look at the actual selection of exercises around that. So today what I'm mainly going to be talking about, as I said, is more to do with the structure of the shoulder. So that real kind of, what are the considerations, what are the things that you need to be thinking about that the shoulder does, how it moves, how it's set up, how it's structured, so that when you are thinking about how you're going to select exercises, you've covered all bases essentially. So with the shoulder there's a number of key points that we want to think about. Yeah. So the first key point we want to think about is this idea of the relationship of flexibility and stability, which we see in all of our joints, and it's particularly relevant within the shoulder. Now, thinking about it like this, so it's what we call an inverse relationship between flexibility and stability. So when we look at any form of a joint, the more flexible the joint is, the less stability it generally has, and vice versa. The greater the stability of a joint, the less flexible it is. So stability can be dictated by the structure, how deep the socket is, how much bony contact it has. Flexibility is generally dictated by the opposite, how little bony contact it is, how shallow the socket joints are, and also the musculature around it. Yeah, so if we take comparisons for shoulder to hip, so that idea of glenohumeral versus femoral acetabulum joints. Now, when we talk about the shoulder, what we find is the shoulder's got a very flexible and as a result very unstable. Yeah, the reason behind it is it's got a very shallow socket, there's not a great deal of bony contact to it, but also from a muscular point of view, there's a great deal of muscles, but they're quite small. Okay, so from an individual force production point of view, each individual muscle doesn't generate a lot of force, but what we get is we've got a lot of muscles generating force within it. So the benefits, the pros and cons here, so the pros are with a lot of muscles, we've got a lot of backups, we've got a lot of support, we've got a lot of things that are going to facilitate multiple movements, multi-directional movements, and very dextral actions. Yeah. From a negative point of view, because there are so many muscles contributing to the force and the movement of the joint, that a dysfunction or a breakdown in one can have a catastrophic effect across the board. Now, the next thing we also want to start thinking about when we talk about the structure of the shoulder and how it works is how it's put together. So if we talk hip, just so we've got a point of comparison, so the hip is what you class kind of, if you like, a two-dimensional or a two-structural joint. It's got its agonist and antagonist, so it's got its muscles that move it, and it's got its stabilizers, so it's got the muscles that hold that socket joint together. When we talk about the shoulder, we have a third dimension to this equation. So we have three distinct shoulder joints. So we've got obviously the AC joint, or the acromioclavicular joint, we've got that glenohumeral joint, which is the main socket joint of the shoulder, but we've also got that clavicular sterno or sternoclavicular joint. Each one's got its own particular role. So with the glenohumeral, this is the main joint. This is where the main agonist and antagonist, this is where the anterior-posterior complex attaches. So this is where you're thinking pecs versus delts and posterior complex. When you then add in secondary to this, we have the clavicular to the AC joint. Okay, it adds structural support to that glenohumeral joint. Okay. Thirdly, we have that sternoclavicular joint, which basically adds support. It attaches the shoulder to the axial skeleton. Okay, so this is one of the main things that is very much overlooked when we look at joint instabilities and joint dysfunctions. Yeah, is that idea of the sternoclavicular joint and how it gives a support strut or acts as a support strut for the shoulder. Okay, so as you can see straight off the bat, without going into any real detail, there's quite a complex understanding of quite a complex structural makeup to the shoulder. So when we do start thinking about exercise selections around this joint, we have to break them down into this kind of into these categories. We need to look at the shoulder and dysfunctions from a point of view as what's potentially causing it. Is it an issue with that glenoid-humeral joint? So is it a problem with either the agonists, antagonists, front to back, push to pull, strong to weak, on how they set that humerus into the socket joint? Is it an issue with that AC and that support and structural support that it gives to the humeral joint? I.e., is it an issue with the scapular versus humerus? Or is it an issue not within the actual shoulder joint itself, but within that support strut attaching the shoulder to the axial skeleton, which gives it support, which we see a lot more regularly than is given credit for, where the actual structure within the humeral joint is fine, but it's that issue within the clavicle, or how the shoulder is attached to the body, which leads to dysfunction. So you really need to look at this. The other element of the three-dimensional effect we see within the shoulder is, unlike, as I said, with that hip joint where we have that push-pull plus stabilizer, here we have push-pull, pecs to posterior delts and so forth. We have that stabilizer in terms of rotator cuff, but we have a third dimension of stability. In here we have the intrinsic scapular stabilizers. So we have the extrinsic scapular stabilizers and the intrinsic scap stabilizers. So these intrinsic scap stabilizers work in two ways. Yeah. So when we talk about a protraction retraction directional point of view, we have quite significant impact with the rhomboids, the mid traps, the lower traps, and so forth, in terms of how they work to antagonize serratus pec minor in that retraction protraction movement. However, when we move into more of an abducted adduction position, so more humeral movement as opposed to scapular movement, these muscles, as rhomboids, as traps, mid traps, lower traps, and serratus anterior, change function. So they change how they contract, they change how they move, and they turn more into a stabilizer. So it's really important from this point of view to take into account not just kind of the pain, where the pain's coming from the muscles, but also the movement that's occurring, and the direction or the positional movement or the plane of movement. If we are experiencing pain, discomfort within that protraction retraction elements, then we may look at it as a strong versus weak, push versus pull, an agonist antagonist imbalance. Whereas if we're getting pain to that abducted adducted plane, or that movement, then it may be more towards a stabilizer problem. So here we have situations where we can have pain occurring in the same place, anterior shoulder, long bicipital grooves, some acromial joints, so on, but have a very distinctly different cause because of the complexity of this joint. All of these things we need to address, we need to take into consideration. Yeah. The other thing that we really need to expand upon is, when we think about the shoulder joint, is this idea of the fact that it is significantly more flexible. Yeah. So when we look at any joint, we need to start thinking about joints and flexibility and range of motions in terms of three distinct ranges. So we have our anatomical range of motion, which is the range of motion of the joint without any restriction, so pure skeletal movements. Okay. Add to that what we call our allowed range of motion, which is the range of motion controlled by stabilizers, structures, and ligaments. So when I talk structures, meniscus and so forth, cartilage, and ligaments. We add a third range of motion to that concept, where we've got the functional range. Now, functional range is the agonist antagonist. So that's where we start thinking about, push to pull, pec versus delt. Yeah. Ideally, what we need to have is, we need to have an optimal range where the agonists and antagonists are working to their best effect while maintaining full range of motion. Now, the problem we arrive here with the shoulder is its increased flexibility means we have a greater allowed range of motion. The issue with a greater allowed range of motion means that we have a greater risk of hyperextending, hyperflexing, going into a greater range, creating more problems on the structures of the joints, from a ligament strain point of view right up until stabilizers, right up until how well the body is able to dissipate force at end ranges. So one of the key factors here we start thinking about is this body's ability to generate agonist-antagonist force through a full range of motion to increase stability as well as force production. If we don't have this, then what we find having is we're generating force this controlled force, as I go to the end ranges of the joint, gets converted into more of a momentum as opposed to a controlled movement. This momentum in itself generates a force exceeding the capacity of the stabilizer joints, which as a result can end up leading to over tears or overuse injuries, impact injuries, meniscal problems, cartilage damage, and ligament strain. So all of this needs to be considered when we start looking at the shoulder. So what we're going to do over the course of, as I said, these videos is we're going to look more into these particular elements. Okay, so we're going to look into the idea of the glenohumeral stability, how it works. We're going to look closer at the scapular intrinsic, extrinsic role of scap stability as well as movement, and we're going to look at that idea of that clavicular, sternoclavicular stability and how the muscles interact with that. Once we can get a really good understanding of these interactions of these differing movements, this flexion or flexibility versus stability relationship, this idea of functional versus allowed optimal ranges, as well as coordinated movements between scapular to clavicle to humerus, then we can start determining A, the cause of our dysfunctions, and B, what the best way is to correct them, and what the best way is to periodize a program to maximize effect in the shortest or best possible time. So please stay tuned. Keep watching for our videos. We're going to look to upload these at regular intervals. If you do have any problems, questions, please contact us here at the clinic, either via our phone number or via social media. All queries, questions are more than welcome. So we'll see you on the next video.